and I request Professor Seema Professor Sarfraz Sen to have a co-chairman seat, please. I request our first presenter, Dr. Levan, to talk on retinal hemorrhage and abusive head trauma.
So I'm going to talk about a topic which is not our favorite topic because it's a topic which, topic which is never fun to talk about, but it's fortunately a very real and important topic everywhere in the world. Why do we even bother talking about this? Well, first of all, any eye injury we see can always be a result of child abuse, right? Secondly, the failure of us to recognize the case of child abuse can always be the first path to a child coming back even more injured. Perhaps the most devastating case of my career was a case in which a child presented with some retinal hemorrhages, and everybody talked about it, the child abuse doctors, the neurosurgeons, we all thought the kid was an accident, and we sent the kid home and he came back dead from child abuse. That's something you don't want to happen to you. So the other reason we talk about it, it is international. This is from the UNICEF page about child abuse here in Pakistan, and it says children in Pakistan are vulnerable to many forms of violence and exploitation, including economic exploitation and child trafficking. Nearly 30 years after Pakistan ratified the Convention on the Rights of the Child, no public coordinated child protection case management and referral system is aligned with international standards. So you don't have mandatory reporting here. And there's plenty of child abuse. And whether it's recognized or not, you do have the child helpline. I was delighted to see as I was driving to the hotel from the airport, the signs on the side of the road advertising the 1211 line that you can call if you feel there is a case of child abuse that needs to be reported, even though you're not mandated to do so. Hopefully we all feel there's a moral responsibility to report. And that moral duty is to protect the children. That's why we went into this business, and also to advocate for children, because children are what we call in bioethics a vulnerable population. They can't protect themselves. They don't have the emotional or intellectual or physical power to promote or prevent some of the things that are unfortunately done to them by adults. There are 4 types of child abuse: physical, sexual, neglect, and emotional. Each one has its ophthalmic manifestations. Physical child abuse can be any injury. On the left, we see a child who an adult now, 35 years old, has angle recession glaucoma from an injury she sustained as an infant. On the bottom right, we see the typical battered child with multiple bruises and abrasions. And in the upper right is a child who had super glue instilled in the eye as a form of punishment by the parent. So all kinds of unusual things can occur, and we have to be the first to recognize them. I'm often asked about, what about intent, right? Was there an intent to injury? And it's important to know that 90% of physical child abuse, there is no intent to injure the child. It's a loss of control on the part of the adult who just loses it and loses their coping ability and then injures. They don't ever intend to hurt the baby as much as may be done. And this is the perfect example. This is a child, one of 8 that I've seen now, who was being disciplined with a belt, being hit on the bum, and the belt buckle accidentally caught him in the eye, sustained a subconjunctival hemorrhage, a hyphema, and also commotional retina. And the father was in the room. The father's crying. He feels badly that he did this to his child. He didn't intend it. That's why we don't recommend discipline using an implement, because you can lose control, and that's what happened here. I've seen one kid enucleated for this. I've seen 2 ruptured globes from belt injuries. These things happen, and they are a form of abuse, whether or not intent to harm was there. The fact that discipline was done in an uncontrolled way is what the cause is. And this girl came to see me, 13-year-old girl, mother's in the room, big black eye, and this is what's on her back, right? This is child abuse. and you as a doctor did not lose your ability or right to examine the rest of the child when you became an ophthalmologist. Sometimes you have to look around, and this is what you find. And there are certain signs that we see, physical injuries, that always mean trauma, right? Laceration, commotio, optic nerve avulsion, vitreous base detachment, orbital fracture. That means an injury has happened. And if you don't have a history, something happened. And then it becomes incumbent upon you not to do the investigation, but to report to those people who can do, social services, the investigation. Other things that are usually trauma, not always, hyphema. Of course, JXG, lesion of the iris, can cause a spontaneous hyphema. Ecchymosis, injury to the pupil, and subconjunctival hemorrhage. So subconjunctival hemorrhage is considered what we call a sentinel injury. So in an infant under the age of 1 who comes with a subconjunctival hemorrhage, there really is virtually no medical cause unless they have thrombocytopenia, leukemia, or something like that, other than birth, of course. And that is a very strong indicator of an abusive, a covert trauma, and a workup is indicated. And then there's other things that happen that we don't think about abuse, but we probably should. Like, why does a kid have a unilateral corneal scar, or unilateral cataract, unilateral ectopia lentis, retinal detachment, optic cataract? Why those things happen? We always have to have, even if only for a brief moment in our mind, the fact that it could be possible abuse. The black eye is one that needs a little bit of care. Periorbital ecchymosis, the skin of your lids is the least attached to the underlying dermis than any other tissue in the body. Therefore, it can accumulate a lot of blood in a short amount of time, making a lesion look older than it really is. I know when this child had their injury. It's from craniofacial surgery. Blood tracked down in the subgaleal space, but you can see there's yellow, brown, all the way to the bright red. We shouldn't be dating injuries. Bruising is a very poor way to say when an injury happened. It just means an injury has happened. And not all bruising is abuse or trauma. These two children have neuroblastoma, which has a predilection for the lateral orbital bone marrow wall, and it can cause this type of appearance. But then again, this is not abuse either. This is a 4-year-old kid who was jumping on the bed, fell, hit her head, got a bruise up here, which tracked down and called bruising on both sides. So not everything. We're not on a witch hunt. We're not trying to find abuse. We're just trying to identify it when it needs to be identified so we can protect the child. As I said, subconjunctival injury is a sentinel injury. This is a child that was brought in unconscious by the mother, saying that she just found the kid in her bed like this. And is comatose in the unit, and I was consulted to see the baby who had this subconjunctival hemorrhage. And this is a result of suffocation. This mother tried to suffocate her baby, a form of what used to be called Munchausen syndrome by proxy, now called medical child abuse. Usually the perpetrator is the wife, the woman, the mother, 97% of the time for some reason. They often had a experience in the medical system themselves. The victim is pre-verbal, isn't allowed to speak for themselves, and we participate. By not participating and not recognizing the diagnosis, we go and we try and find this and that. We keep going. Maybe it'll be Levin syndrome, and what we're doing is missing what's hiding in plain sight, which is an injury that was caused by the parent. There have been many forms of medical child abuse. There's been subconjunctival hemorrhage is the most common from covert suffocation. This is real. We have covert videos in the hospital of parents overlaying their kid, suffocating them, trying to just get the attention of the medical world to bring them care. Pupillary abnormalities, nystagmus, strabismus can come from covert poisoning. Corneal scars from chemicals inflicted in the eye. One patient had bilateral corneal transplant as a result of chemical put in by mother's boyfriend. Periorbital cellulitis from injections around the eye. There's even a case of needles put in the eye. These things happen, and we have to recognize them, or the kid will go on to be murdered. Shaken baby syndrome is a form of abusive head trauma. We are all aware of this. We know there's characteristic brain injury, subdural, subarachnoid, diffuse axonal injury, skeletal injury, and of course eye injury, retinal hemorrhages. Are there other causes of retinal hemorrhage? Sure, there's plenty. But you have to ask, what do you mean, right? And that's why it's so important to detail what we see in the eye. The top picture is a non-specific, many things could cause that top picture. The bottom picture is a cavernous meningioma of a capillary meningioma of the retina. We know that. There are many things that are not abuse, but our job is to identify those things that are abuse. And not all retinal hemorrhages are the same, right? But when you see hemorrhages extending to the ora serrata, that has a 14 or 15 or some papers 30-fold increase in the chance that it's child abuse over an accident. This is non-specific. Could it be child abuse? Yes. But this is the kid's other eye. Too numerous to count pre-retinal, intraretinal, subretinal hemorrhages extending to the aura. That's what we see in 2/3 of cases. And then there's a traumatic splitting of the retina. As the baby is submitted to acceleration, deceleration forces, the vitreous pulls off the retina. You get this kind of cystic appearance of the internal limiting membranes elevated with a blood serum level that forms inside. This is what it looks like in real life. Here's another one here. And, here's the retinal fold that can be raised from the vitreous pulling on the retina. Here it is in a paper we published. You can actually see the vitreous pulling on the retina. Fantastic photograph. If you're less than 5 years old and have macular retinoschisis, there are very few things which cause that. That would be a fatal head crush injury, 11-meter fall onto concrete, or a fatal motor vehicle accident. Short of that, it's child abuse. And we've done a paper, this is probably the largest paper ever written, of kids with shaken baby syndrome when I was in Canada. 2/3 have too numerous to count retinal hemorrhages throughout in multiple layers. But note that 85% of hemorrhages, 15% have nothing. So the absence of retinal hemorrhages does not rule out abusive head trauma. They can be unilateral and asymmetric, and papilledema is rare. So when you see these kids, consider the number of hemorrhage, the pattern of hemorrhage, the type of hemorrhage, symmetry. All these things are very important in coming to a conclusion about what happened to this baby. There is a differential diagnosis, but it's small. Leukemia, you'll usually also see retinal infiltrates. Birth, we know the dates by which hemorrhage is resolved. If you're 3 months old, have retinal hemorrhage, it's not from birth, right? Ruptured aneurysm, but you know it's ruptured aneurysm from the neuroimaging and head crush or motor vehicle accident. Not much more causes this. Things that don't cause retinal hemorrhages, COVID. COVID vaccine does not cause retinal hemorrhages. We've just finished the study of this in many children. It's been in court. The defense will come up with theories, doesn't. Increased intracranial pressure causes hemorrhages on or around the optic nerve, not throughout the retina. Cerebrovenous thrombosis doesn't do it. Short falls don't do it. Hypoxia doesn't do it. CPR doesn't do it. Not a lot of hemorrhages. So you can, by taking a careful history, know when you're in the right ballpark. The two outliers are epidural hemorrhage. There's a small study of 9 kids, of which 5 had retinal hemorrhage from Children's Hospital Philadelphia. So that can rarely occur. Intraretinal hemorrhages confined to the posterior pole. Occipital impact, for some reason we don't understand, does make worse hemorrhages. There's a paper of 8 witness falls, less than a meter. They all had immediate symptoms, and 1 even died from a short fall. 7 of 8 had retinal hemorrhages. 4 were bilateral. 3 had subretinal hemorrhage, something very rare in accidental trauma. 3 of 7 went to the periphery, but no one had macular retinoschisis. So this is a weird situation, and we don't know what to say about that, but it certainly is something that's real and should be considered. Of course, you should have evidence or a history of an occipital impact. Sexual abuse can also result in eye problems. It's a different dynamic. It's usually chronic. The perpetrator holds a position of power over the child. The child is either coerced not to tell or is afraid to tell, or maybe doesn't even know it's wrong. We see sexually transmitted disease in the eye. On your left is pubic lice. On your right is neonatal gonorrhea. Neither of these are sexual abuse. Neonatal transmission of sexually transmitted disease is an abuse. It needs to be treated, obviously. And we know a lot about this now. We know that Syphilis, unless it's congenital syphilis, which is its own syndrome, is always transmitted sexually. We know that gonorrhea, chlamydia, and pubic lice may be transmitted non-sexually. There's good evidence for that in young children. But if you have these infections in your genitalia or in your throat, then it's not an accident. Those things are sexual. When they're in the eye, they are a question. Neglect is another thing that's very important. This is a child who was thrown into a latrine in Africa. The parents tried to kill their baby, and the baby lived, but the acidity of the human waste caused bilateral corneal blindness. But there's another form of neglect, and you can see it here on the streets and everywhere, large parts of the world, where children are beggars and are out on the street and not in school and not being cared for properly. That's a form of abuse, and it can have eye problems, just like that boy there with corneal opacity, just the lack of care. If that child who's a beggar, he has a cataract, is he going to seek care? No. He's got glaucoma? No. And that neglect can also lead to problems. And, if you have a patient who's not coming, who's not there, take a good history. Sometimes there are good reasons. There may be reasons they can't come. The distance is far. They can't afford to come. Maybe they don't know it's important to come. But also, is there damage? And what is that damage, and what can you do about it? And we get to this, macro, meso, micro. We can't fix the whole world. There are some systemic problems in the world of inequality and poverty that we can't fix. There are meso, local problems that are hard to fix. What we can fix is the problem in an individual child. And we can intervene when we see it and do something for that child to give them protection and advocacy. And lastly, emotional abuse. You can just see the look on these kids' eyes and these kids' faces that their lives have been affected by child abuse. And what children see is a form of abuse. This is a study from Chicago. Over 1,000 kids in middle and high school were looked at. 35% had witnessed a stabbing. 39% had witnessed a shooting. A quarter had witnessed murder. In high school and in grade school, 30% had witnessed a stabbing. A quarter had witnessed a shooting. Nowadays, especially in the United States, it's rampant. And our children shouldn't be seeing these things. Our children shouldn't be seeing drug abuse. Our children shouldn't be seeing sexual activity, all kinds of things that children are exposed to in the media, on social media, on the internet. Australia just banned social media for kids under 16. This is an important problem. Remember that bad families can have great parents. Just because a family has difficulty doesn't mean the parents can't do a good job. They can. But likewise, the best families you see, the rich families, the very perfect families, can also be very bad parents. No one is immune from being a perpetrator of abuse. The perpetrators is anyone. People like you and me who lose it, who just act of control. They come home after a hard day. They're put to that extra stress. 90% of physical abuse is unintentional. The other 10% are by psychotic individuals who do crazy things, except for sexual abuse, of course, where it is planned and calculated and suppressed year after year. Your job is to report suspected abuse. You don't have to prove abuse. There's no law in the world that makes doctors, policemen, or judges. All you have to do is do the right thing and report suspect. And suspicion that is reported usually will lead to help. Not always, but not suspecting and not reporting will never lead to help. It'll lead to more harm. You can make a difference. Realize that. You're in a position, a very special position as physicians, that you can intervene and help a child save their life, for goodness sake, by just doing the right thing when you see it. Thank you very much. Happy to take any questions. Questions?
We can take at the end of the session.
Okay. Good.
Thank you very much, Dr. Levin, for your elaborative talk on abuse of head trauma. Now I request Professor Seema Qayyum Seba to have a talk on eye, a window to systemic disease. Meanwhile, our co-chairman, Professor Madhur Hassan Saab, has arrived, and I request him to take the chair.
Assalamu alaikum and a very good evening. The presentation which I'm going to make today is just my 20 years of career in pediatric ophthalmology. I started in 2000, and I retired from my job from Children's Hospital in 2020, and this is a major part of my career. So owing to the eye, the soul is content to stay in the bodily prison, for without it, such bodily prison is a torture. So I'm just going to talk about how an ophthalmologist can see inside the body through an eye and pick up so many diseases which when you are the first one to pick them up and then send them to the right place. So talking about that, most clinicians ignore ocular involvement of systemic diseases, which is very, very, very important. And I had the privilege of working in an institute where we have more than 40 specialties, pediatric specialties under one roof. So we had, like an inflow of children from gastroenterology, from medical department, from endocrinology, from neurology, neurosurgery. So I think we were very, very privileged to see all these patients, which was an blessing, I think, in a way that we learned a lot. So, talking about my first, this is a routine eye examination can sometimes become a very life-threatening disease. In our outdoor, it was not very infrequent for children to walk in with a complaint of simple headache. And most of the time, patients were referred to our department by the Department of Neurology just to see the fundus. The patient walks in with headache, and sometimes that's what we used to see, simple headache. And a simple eye examination can pick up the disc edema, and then, we have to, they refer to the right department, and the right treatment may follow. And the only question you have to ask him is only that whether the headache, how is it cured? Does it disappear by taking a paracetamol? Is there any other problem with the child? His fatigue, lethargy, difficulty in playing, and things like that. But and I used to, sometimes my residents or my students used to get very irritated. Madam, why do we have to dilate every patient with a headache? Why does the neurology people do not see the fundus? And the biggest complaint was, Madam, at 1 o'clock they send the patient for a dilated fundus examination. Now we have to sit and dilate the fundus. I used to say, if you cannot dilate the patient, at least look into the eye. Just an undilated pupil, also with an ophthalmoscope, you can see the disc. And it was not very infrequent to find a disc edema, papillary edema, and then an MRI or a CT, and but not. And a space-occupying lesion was timely diagnosed. Then pseudotumor cerebri, it also presents like this. And we can sort if there's this papillary edema and there's no raised on a CT or an MRI, you don't get an SOL, then they're labeled as a pseudotumor cerebri. The retinoblastoma, just looking, just the white reflex, leukocoria, seeing that you identify a retinoblastoma. Blood dyscrasias, they present in a very surprising manner. This is, if I would say, this patient presented to the eye department first. He did not go to the oncology. There was just an increase in the size of the eyeball, and he was just a simple CBC, which doesn't cost a lot, maybe 200, 300 rupees, and that's all. And this appearance and a CBC, and he had a blood dyscrasia, and he was then referred to the Department of Hematology and Oncology. Then pathologies of coagulation system. Alex was showing, yes, trauma, abuse can lead to this, but again, get a CBC done, and get a CBC done. Sometimes there are problems of the coagulation system. Get your prothrombin time done. Mujitna, I'm not very familiar because I've not been working in the department now for the last 5 years. I have, in my mind, I do not get those all difficult names. I've sort of put them right back in my mind. I do something else now. So, but get all those prothrombin time and get a CBC done, and you will be helping the child a lot. The non-functioning immune system. These are the children which present to you CMV infection in a patient with AIDS. I saw this patient. This is my own patient. This was the picture and a simple torch tests, we were able to identify this. And actually, after we seeing this patient, he was diagnosed as AIDS. It was not that he came to us from them, we sent them to them. Herpes zoster, an immunocompromised child. He was on he was on chemotherapy. Then inherited metabolic disorders, Wilson disease, copper deposition. These were the patients who were referred to us from the Department of Gastroenterology, and that was their diagnostic marker. Then sunflower cataract and Wilson's disease. So we helped them in the diagnosis, galactosemia, the oil droplet cataract. Cystinosis, nephrology department, they always burden us with their patients, just look at the cornea and see whether they are cystine deposits or not. So a simple slit lamp examination helps in the diagnosis. Alpert syndrome, the lens, because when they're able to come up with the diagnosis. And in a syndrome, as we all know, that is a multi-organ or multi-system diseases. So this helps in the diagnosis. Senior Loken syndrome, again, a picture like this, and a problem in the kidneys. Usher syndrome, deafness, retinitis pigmentosa, and renal diseases. Gyrate atrophy. This is a simple thing. If you identify it, is manageable. Tay-Sachs disease, cherry red spot. So we get these patients from the Department of Gastroenterology. Mucopolysaccharidosis, sometimes they misdiagnose as glaucoma. So yeah, if you have a child like this walks into it, you have to do the intraocular pressure, you have to do the axial length, and consult the pediatrician. These are very typical picture. This is a very typical facial features: thick skin, thick coarse skin, a flat nose, corneal haze, this type of expression, short stature, kyphoscoliosis, homocystinuria, NRED के साथ आने, dislocated lenses. They land over dislocated lenses, and then you refer them back to the Department of Pediatrics. Waardenburg syndrome. This is a very interesting. This was a family. The father also had heterochromia and a white forelock, and both the siblings. I found them very interesting. Tuberculosis, sometimes filictinellar conjunctivitis. It's not responding to anything. Get a Monto's test. Rule out tuberculosis. Then this girl who was here, she had this lump here, not responding to any antibiotics. She went to different centers, and when she was just not responding, we just did a Monto's and a chest X-ray, and she was diagnosed as tuberculosis. And tuberculosis is not uncommon in Pakistan. It's very, very common. So you have to remember, your simple Monto's test, not very expensive, not very difficult. You just get that done, and you will be able to diagnose tuberculosis. Shabir syndrome. This is very, very common in a very one particular caste in Punjab. So in them, this is very common, and this got a very fancy name to it. At the moment, I cannot remember that. Oculodermo something करके होता है. It's a big name. आपको याद होगा. Yeah. I can't even pronounce it because they have some trouble in the larynx, and this is a very advanced case, but sometimes they only come, you just have to see the nails. If you see non-responding ulcers, conjunctivitis, adhesions, just look at their nails, and you just look at the nails and you can identify Shabir syndrome. Hubert syndrome. This is a girl who walked into a department with a staggering gait and very variable type of deviation, which you cannot put into any particular type. You just get an MRI done, and this is the molar tooth sign, and this is a case of Hubert syndrome. Then this is a battered child. Sometimes it is intentional and sometimes it is unintentional, because I've seen a lot of mothers or the caregivers, when they want to put the child to sleep, they do this. They just bang the head, and when they're doing it, sometimes it is so hard that this happens. So you have to tell the mothers, please don't do this. Kande se laga lo, put the child on the shoulder, tapak tapta do, but they do this. And sometimes the mother's hand is very heavy. And I did receive a child, the mamu, the maternal uncle, aise uchala aur pakda. Mujhe khilate hain. He threw it, remember, he was not able to hold the child, and the child. I mean, when he brought the child to Adepa, he was crying and crying and crying because he was just playing with the child. It was totally unintentional. So this is a thank you.
Thank you very much, Professor Seema Qayyum. Now I request Professor Surat Nurani to present a talk on pediatric cataract surgery in different scenarios.
So congenital cataracts are responsible for 5 to 20% of blindness worldwide, and incidence varies from country to country. In the US, the prevalence is of visually significant cataract is 4 in 10,000 live births. In UK, it's 3.18 per 10,000, and in Asian countries, it is 3.8 in 10,000. And this Asian study was conducted by the meta-analysis at Dow University of Health Sciences, and I think published in 2022. Cataracts may be unilateral or bilateral. They vary in size. We all know that. Morphology differs. It may be a small dot in the anterior capsule, or it could be the total opacification of the lens. Prompt treatment of visually significant cataracts is necessary to allow proper visual development. We all know that. And there are some visually significant cataracts and non-visually significant cataracts. So I'll talk about the visually significant. If the cataract is 3 millimeter and more, if it lies posteriorly or centrally, obscuring the posterior pole, or present with associated with strabismus or nystagmus, then yes, it does require surgery. Timing, unilateral cataracts are operated 4 to 6 weeks of age, while bilateral at the age of 6 to 8 weeks. If you operate them early, then there are chances of aphakic or pseudophakic glaucomas. The surgical approaches, if the child is less than 1 year of age, then lensectomy, posterior capsulotomy, and anti-vitrectomy is performed, leaving the rim of the capsule behind for the future IOL transplantation. And obviously, optical rehabilitation with aphakic glasses or contact lenses is must, followed by amblyopia management. If the child is 1 year old, then we can do lensectomy, posterior capsulotomy, anti-vitrectomy, and at the same sitting, IOL implantation. And these children require careful refractions as well. If the child is 5 to 7 years of age, then posterior capsulotomy may not be necessary, but if the child is mentally compromised, or if the child is having nystagmus, then you can go for so it depends on the scenario. It's very important point that pediatric eye is not a small adult eye, and management of pediatric cataract is different from that of adults. We all know that, right? Why? Because of the anatomical younger tissues, low corneal and scleral rigidity, very elastic anterior capsules, soft lenses, well-formed vitreous. These all factors, they make the pediatric cataract surgery complex and challenging, not only intraoperatively, but postoperatively as well. There's increased association of post-op inflammation, PCO. There is constantly changing refractive state due to continuous growth of the eye, which doesn't happen in adult eye. And poor compliance with post-operative medication and follow-up problems. These are the common problems in pediatric cataract surgery. So you really have to do good counseling with the parents. And long-term follow-up is required for amblyopia management and for the management to evaluate for the glaucoma as well. The surgical technique which we use is bimanual irrigation aspiration techniques with the help of the AC maintainer. It's a beautiful small instrument, but really helpful in pediatric cataract surgery. It maintains the AC. It doesn't let the iris touch. It prevents iris prolapse. It allows you for the proper aspiration of the cortical matter. If you leave the cortical matter behind, for sure you are going to have post-op inflammation and complications and re-ops. The high-speed vitrectomy instruments, the use of these instruments has reduced the retinal traction and long-term retinal risks. Iris hooks are used in immature iris. I'll show you the cases, but these cases must be used gently because tissues can be easily damaged and it can lead to fibrinous reaction and cosmesis of pupil, poor cosmesis of pupil. So there's long list of pediatric complications of pediatric cataract surgery, but if it is performed by the experienced surgeon, it should be performed by the experienced surgeon, and the proper instrumentation is used, the techniques are followed, then it goes smoothly. So here are a few of the cases which I have recorded for the training purposes and the teaching purposes and sharing the experience. So this is the congenital cataract in a child with difficult to dilate pupil. Always remember, if the child is having difficult to dilate pupil, the nuclear cataracts or microcornea cataracts, there's a high risk of aphakic glaucoma. So these children, they need to be monitored post-operatively frequently. So for the proper clearing or the cleaning up of the cortex matter, it is very important. The exposure is very important. If you're not being dilated with the drops, you have to apply iris hooks. But use them gently. It's a beautiful instrument. It helps you a lot. But use them gently and see, with the help of the exposure, you are able to see the entire lens and you can do the surgery easily and remove the cortical matter. If you don't use the hooks, then for sure you're going to leave some cortical matter behind, and it is going to induce inflammation, and that will require reoperation and increased chances of glaucoma. AC maintainer helps you really a lot, prevents iris prolapse, which is also responsible for the post-op inflammation in the child. Sometimes you can use it as a chopper, as I did in this video, to chop the calcified part. See the exposure is so good, the AC is well maintained with the help of the AC maintainer, and you can clean up the cortex. Always when if it disengages, you can engage it again. And there is a proper technique to remove it. Don't just pull it out immediately. It will cause the swelling of the AC, plus the iris will come in the wound, which will also incite the inflammation. Respect the iris tissue, the tissue will respect you post-operatively. So move the stopper, rotate the hook, disengage from the pupil first, then take it out from the eye. And then microsuture is used. Here is another case of PHPV. There's a membranous cataract and full of the vessels, right? So in these cases, there's a chance of the hemorrhage. So what we usually do, we use intraocular cautery to cauterize the vessels first, and then again the same technique, use the iris hooks for the exposure, and then these are usually membranous kind of cataracts, so you make a hole in it. If it is really tough, you can use the MER to make a small hole, or primarily you can do it with the eye of the cutter. This vitreous cutting instruments are really helpful in these cases. So make a small hole with eye of the cutter down, then engage this hole in the cutter with eye up and do the cutting. So cutting is used if the tissue is thick, you can reduce the rate of the cutting. And see how nicely my AC is not being collapsed. This is only because of the use of the AC maintainer. So you can be really close to the ciliary processes. You have to be very careful, because if it is cut, then it can lead into the hemorrhage as well. So another technique, if it is not soft, if it is not being cut with a cutter, you can use the intraocular scissor, just make a neck snip to make the edges, and then and then remove it with the help of the cutter. So this bimanual irrigation aspiration technique, especially with the use of the vitrectomy instruments, it's really helpful to perform the surgery smoothly and to have the post-op results without inflammation, and to prevent the chances of the re-op. So this is how I remove the hook. I never pull it at once. Just move the stopper and then rotate it and disengage it. So sometimes, yes, IUL is indicated at the age of 1 year, but sometimes when I see that the corneal diameter is 11-ish and the axial length is 20 millimeter, then I go for the IUL implantation at earlier age, like in this case, 8 months of age. How I was trained that we always use scleral tunnel. I don't do corneal tunnels, but it depends on the preference of the surgeon. You can use the corneal tunnel as well, but we always use a scleral tunnel. And then again, AC maintainer is in place, and in these cases, the rhexis is challenging. At any point, if you think the AC is getting shallower, use the come out. See, in pediatric cataract, you don't count the time. Like the adult surgeons, they say, how much time do you take to take phaco? Oh, I do it in 5 minutes. Oh, I do it in 7 minutes. But it doesn't happen in pediatric cataracts. So if at any point, if you feel your rhexis is being extended, use the viscoelastic, do it nicely, because the rhexis is very important for the centration of the IUL if you put the IUL in the bag. Again, nicely engage the soft, this gummy cortical material, and then aspirate it with high suction. And similarly, when the bag is empty, see how nicely I'm doing AAC capsular polishing. These are the cells which are responsible for the posterior migration. If you leave them, they will posteriorly migrate and cause the opacification of the posterior capsule. So it is very important to do the AC polishing as well. And then inject the IUL in the bag. It is very important to inject the IUL in the bag, but there are some scenarios when you don't have in the case of posterior lenticonus, then you can put it in the sulcus with optic capture as well. Okay, so I have stopped doing pars plana posterior capsulotomy since I learned this technique. I do the IUL, I suture the primary wound, the scleral wound, and then I go behind the lens. First, settle down the lens in the capsular bag, and then with the help of the cutter, just elevate the edge of the lens. I put the haptics not horizontally, so that I can have the space to put my cutter inside and do the posterior capsulotomy and anterior vitrectomy with limbal approach. And then come out, settle the lens in the bag again, dial it properly, and overlap the edges on the top of the optic nicely. Okay, this was the different case. This child presented with ET. So I was expecting cataract in this child, but what I found, I saw the membrane first. There was a thick fibrous membrane. So what I did, I thought there is going to be a cataract underneath, but then I realized there may not be cataract there. So I lifted the membrane with the help of the viscoelastic, and then I used the cutter with the eye up, not to open the anterior capsule. So I used the cutter eye up, and then I did the membranectomy and the slight pupilloplasty as well with the help of the cutter, the high cut rate. And then what I found shortly you will see the retroillumination, the lens is crystal clear. So I just did the membranectomy and little pupilloplasty, just to trim the these membranous extra membranous edges near the pupil. Here, see the cataract is the cataract is not there. The lens is clear. Sometimes with the opaque lens, you will see the dusty opacity surrounding the main opacity. So this gives you the clue that there could be the primary gap in the posterior cap. So there could be posterior lenticonus. So in these cases, you have to be prepared that you want the rexes in this case so that you can implant the IOL in the sulcus, right? These are the unilateral cataracts, but I have seen this posterior lenticonus bilaterally as well. So in these cases, intact anterior capsular rexes is very important to place the IOL in the surgery. Don't leave the child aphakic. The child is 1 year and older. So again, go gently. If you feel that rexis is being extended, put the viscoelastic and pull the rexis towards the center. Just pull the rexis towards the center, and it will be controlled. It will come back to the center. You will have the adequate side rexis. See how nicely it was done, and it is done with the help of the when the AC is well maintained, use of the copious use of viscoelastic. Another tip in posterior lenticonus: don't do hydrodissection, because with the help of the hydrodissection, the lens matter can go into the posterior cavity. And when you engage the lens matter, just suck it. Don't let it go. If you let it go, then it may drop into the posterior vitreous cavity. And you can see how big the gap is. See, so it is very important to have the rexes, and then to put the IOL there on the top in the sulcus, and then you can do the optic capture as well. So this is the last case, is the case of the ectopia lentis. I did the sclera fixation in this, but I just want to show you the lensectomy. See, it's 3 quadrants, the zonules are not there. So you can use the iris hook to move the iris, engage the iris, plus you make a small hole in the capsular bag, and then you can put the hook in the bag so that you will not drop the lens. Then take your cutter inside the bag. This is known as in the bag lensectomy. Engage the lens matter with high cut rate and suction. Don't let the matter go. Once it's in the eye of the cutter, just suck it. Don't let it go. So empty the bag first. Shortly you will see that the bag will be empty of the this cataractous material, and the entire bag is there. Then eat up the bag and do the anterior vitrectomy, and then close the wound. So this is known as, see, the bag is there. I have removed the cortical matter, and then eat it up with a high cut rate and do the this anterior vitrectomy. So these were the few cases I wanted to show you. So in conclusion, a pediatric eye is not a small adult eye. Pediatric cataract surgery is challenging. It should be performed by an experienced surgeon. Bimanual irrigation aspiration is a preferred surgical technique. Use of AC maintainer and retractor has reduced the rate of surgical complications. Parental counseling is very essential, because follow-ups, putting the drops in a child, and frequent refractions, and make them wear glasses. This is very important to prepare them before surgery. Long-term follow-up is required, and periodic refraction and amblyopia management is an essential part of pediatric cataract surgery. Thank you very much for your attention.
Thank you very much, Professor Sultan Rani, for your excellent talk. Now I request Dr. Sara Farooq to have a talk on Shabir syndrome.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Dr. Sara Farooq. I am a PGR from Jinnah Hospital, Lahore. So today the topic is Shabir syndrome. It is also known as laryngo-onychocutaneous syndrome or the Locke syndrome. So here is a case presentation of 10 years old girl who is resident of Lahore. She presented in OPD with on and off watering and irritation of eyes, difficulty in breathing, hoarseness of voice, painful skin lesions on various body parts since childhood. So on detailed history, we came to know that her mother noticed these cutaneous erosions on various body parts, including neck, elbow, hands and knees. It was associated with malformed nails. She presented in derma department where it was labeled bullous impetigo, for which she is taking treatment. Mother noticed that the cry of the child was hoarse during infancy. The child was also having low HB, for which she has been transfused thrice up till today. There was irritation and watering of eyes, for which she has been taking antibiotic eye ointment, tobramycin, and lubricant eye drops. So she has been operated 4 times for excision of granuloma. There were multiple hospital admissions, multiple blood transfusions as well. So on asking the past ocular history, we came to know that she was taking antibiotic ointment and she had 4 episodes of granuloma excision. The history of glasses, trauma, injection and laser was insignificant. So on asking family history, we came to know that same symptoms were present in younger sibling who was 5 years old. He had these skin erosions on the neck area. There was conjunctival granuloma on the left eye. So these are the 2 siblings. Socioeconomic history, patient belonged to middle class family. On ocular examination, we came to know that visual acuity was 6/6 in both eyes. Extraocular movements were full. Conjunctiva, as you can see in this picture, there is temporal granuloma in the eye. And cornea was clear, aqueous humor was adequate, and lens were clear. On doing the posterior segment examination, the disc was grossly NAD and macula was healthy. So on systemic examination, general patient was having good appetite and energy, and he was having stridor and various cutaneous erosions on doing the examination of skin. Rest of the examination was insignificant. So you can see these pictures. There is cutaneous erosion on the elbow. The skin fragility is present on the hand. Same on the knees, on the ankle. So hypergranulation tissue was also present on the knees. This is a characteristic feature of Shabir syndrome. This is also present in hands. So this is a collage. You can appreciate both brother and sister and these cutaneous lesions and hypergranulation tissue. So what is Shabir syndrome? It is a rare epithelial disorder of autosomal recessive pattern. It was described by Pakistani dermatologist Ghulam Shabir in 1986. It is caused by mutation in LAMA3 gene, and which provides instructions for making a subunit called laminin 332. So when the laminins are defective, epidermis cannot effectively attach with the lower layers of skin, or it is difficult for wound healing. These abnormalities cause the cutaneous erosions and overgrowth of granulation tissue. So what are the characteristics? As we have named it laryngo-onychocutaneous syndrome, so there are abnormalities in larynx, nails and skin. So these are the characteristic features. Affected individuals often have impaired or complete loss of vision due to tissue overgrowth. There are cutaneous erosions or missing patches of the skin. People with Locke syndrome have malformed nails and abnormal teeth. There is laryngeal stenosis and anemia is also reported. It is also categorized as junctional epidermolysis bullosa because this is a subtype and it is characterized by a fragile skin that blisters easily. So that's all. Thank you.
Thank you very much, Dr. Sara Farooq, on your talk on Shabir syndrome. Now I request Dr. Andaleeb Zahra to present her talk on atypical presentation of retinoblastoma, a diagnostic challenge for ophthalmologists.
Bismillahirrahmanirrahim. Topic of my presentation is atypical presentation of retinoblastoma, a diagnostic challenge for ophthalmologist. What is retinoblastoma? It is a most common primary intraocular malignancy of childhood. Arises from the immature retinal cells. It can be unilateral or bilateral, maybe unifocal or bifocal, multifocal, maybe hereditary or non-hereditary. Common presentation of retinoblastoma. Most common presentation of retinoblastoma is leukocoria, and to some extent, patients are presented with strabismus. You can see the pictures of two children, both presented with leukocoria, or parents noticed cat's eye reflex. Another picture of two patients, both have leukocoria. Also, patients have history of strabismus. You can notice strabismus in both patients. Initially, both patients developed strabismus, and after few months, when there is cat's eye reflex, then the parents bring the child to the hospital. In retinoblastoma, late presentations with orbital involvement, mostly ignored childs, or initially they refuse the treatment, then presents with orbital involvement. Today we discuss the atypical presentations of retinoblastoma. First child, 5 years old child, it presented with left thicical eye. Initially, a few years ago, child had history of redness of eye and was treated by some ophthalmologists as a case of endophthalmitis. And according to parents, after this treatment, the eye got shrunken in size, and now they presented with thicical eye. In the right eye, there was also history of reduced vision. When we do the examination under anesthesia, we came to know that there was a right group D retinoblastoma, and in the left eye, it was thicical eye and no view. When we perform the B-scan ultrasonography and do the MRI of the orbits and brain, it came to be a case of bilateral retinoblastoma. This is another child, 5 years old child. It is presented to us with a history of some trauma. Just they are suspecting there may be some mild trauma, but history was not adequate. Patient presented with hyphema, and after 3 days, when somehow there was settling down of hyphema, we found that there was NVIs and anterior chamber was collapsed. Fundoscopy was performed at that time, and it was found to be a group E retinoblastoma, also detected on B-scan ultrasonography and MRI that it is a group E retinoblastoma. Later on, histopathology also confirms the diagnosis of retinoblastoma. 2 years old child presented to us with left vitreous hemorrhage. Examination under anesthesia showed left conjunctival congestion, NVIs, and vitreous hemorrhage with no fundal view. But the B-scan, ultrasonography, and MRI shows left retinoblastoma. And later on, after enucleation, histopathology also proved the diagnosis of retinoblastoma. This is a very unfortunate child presented to us with new vascular glaucoma. Patient was on anti-glaucoma medication. According to the history, at the age of 18 months, child developed leukocoria, and the parents visited subophthalmologist that diagnosed the case as a case of retinal detachment. And later on follow-up visit, patient was labeled as a case of new vascular glaucoma secondary to long-standing retinal detachment. So they started anti-glaucoma therapy to the patients, but no, patient presented to us with painful blind eye in spite of taking anti-glaucoma medications. When we examined the child, there was hyphema, NVIs, anterior chamber was totally collapsed, and it came out to be a group E retinoblastoma. B-scan, ultrasonography, and MRI was performed, which also, unfortunately, there was intracranial extension of retinoblastoma up to the optic at the level of optic chiasma. This is another girl, 4 years old girl, presented to us with left hypopion. But when we do the examination, and later on we also perform the examination under anesthesia, it was found to be a case of group E retinoblastoma with tumor cells in the anterior chamber. Another child, 5 years old child, presented to us with left hypopion. Examination under anesthesia confirmed left group E retinoblastoma with tumor cells in the anterior chamber. This is another case. 3 years old child presented to us with dystopia and cheek swelling. On B-scan ultrasonography and MRI brain, it shows a left retinoblastoma with orbital involvement. Take-home message: atypical presentations of retinoblastoma are not so uncommon. There must be some advices. Always take a good history from the parents. In suspected cases, always plan proper examination under anesthesia and examine both eyes. In case of no fundal view, B-scan ultrasonography should be done by some experienced ophthalmologist. MRI orbits and brain can be planned in suspected cases of retinoblastoma, and close follow-ups in suspected cases of retinoblastoma is mandatory. Like in case of this is a new vascular glaucoma. It was initially detected at 18 months of age when the patient presented through leukocoria, but B-scan ultrasonography shows retinal detachment and no proper follow-ups. Then it was detected as a case of new vascular glaucoma, and finally at the age of 5 years patient presented to us when there was intracranial extension. So close follow-up in suspected cases of retinoblastoma are mandatory. Thank you so much.
Thank you very much, Dr. Naveeb Zahra, on your excellent presentation on atypical presentations of retinoblastoma cases. Now I request Dr. Rashid Beg to present ocular abnormalities with beta thalassemia.
Assalamu alaikum, Bismillahirrahmanirrahim. So today I am presenting my study, Burden of Ocular Abnormalities in Patients with Beta Thalassemia, a cross-sectional study. I do not have any financial disclosure regarding this presentation. Beta thalassemia is an area of hereditary blood disorders which are characterized by abnormalities in beta globin chain synthesis. So this study is basically about beta thalassemia and its ocular effect. As we know, beta thalassemia is one of the most common single gene hematological disorder resulting in defective beta globin chain synthesis, highly prevalent. Pakistan shows a carrier rate of 5 to 8% approximately, with 5,000 new patients diagnosed with thalassemia major each year. Thalassemia is a multisystemic disease affecting multiple organs. Ocular findings reported in literature may vary from lens opacities, retinal pigment epithelial mottling, POD orange fundus, features resembling pseudoxanthoma elasticum, to pale optic disc and visual field defects. Several systemic complications of beta thalassemia major have been reported. The objective of the study is to determine the overall frequency of ocular complications in patients with beta thalassemia, such as retinal pigment epithelial degeneration, visual field defects, lenticular opacities, anterior segment abnormalities. Secondly, to identify factors associated with ocular complications in patients with beta thalassemia, such as socio-demographic factors, use of iron chelating agents, number of transfusions, splenectomy. It is a single-center observational prospective study which is conducted at the Department of Ophthalmology and Visual Sciences, Aga Khan University Hospital, Karachi. 203 participants from Fatmeen Foundation were entered, assessed and examined by a single consultant ophthalmologist at the Aga Khan University Hospital. OCT, visual fields, fundus fluorescein angiography were undertaken when necessary as per the examining ophthalmologist. This study involves the human participants, so ethical approval was sorted out from the Aga Khan University Ethical Review Committee. Permission was taken from Fatmeen Foundation for recruitment of beta thalassemia patients. Written informed consent from parents were taken in English or Urdu depending on the understanding of the participant was taken by a trained data collector. Participation was explained and it's voluntary. Data was analyzed by SPSS version 12, the relationship of variables with the outcome ocular complications was assessed by independent t-test or Mann-Whitney U-test as appropriate. Unadjusted and adjusted prevalence ratio with their 95% coincidence were reported to determine the association of independent variables with ocular complications by Cox regression algorithm. A p-value of less than 0.05% was considered significant throughout the study. Overall, socio-demographic characteristics of beta thalassemia patients. The total 203 patients were enrolled in the study. Out of these, 109 were males and 94 were females. There is a family history of ocular complications in 33.5% of patients, parents and both siblings. Frequency of ocular complications with beta thalassemia patients, overall ocular complications was 22.7%, in which color vision abnormalities were present in 5.9%, corneal opacity 1%, lens opacity in 4.9% of patients, iris abnormality 0.5%, disc hyperemia in 1%, retinal peripheral abnormality in 7.9%, optic nerve abnormality 11.8%, and retinal macular abnormalities in 10.3% of patients. In this cross-sectional study, we describe various ocular manifestations of beta thalassemia due to the disease itself and iron chelation in association with clinical and biochemical parameters. We report overall 22.7% of the patients with beta thalassemia had ocular complications. Higher proportion of males, 88% were found to have ocular complications, is significantly higher median serum ferritin levels were observed in patients with ocular complications versus those with no ocular complications. A unique observation of low median calcium levels was seen in patients with ocular complications versus those with no complications. Interestingly, with every 1 unit increase in serum calcium levels, the prevalence of ocular complication decreased by 24%. No significant association with other socioeconomic or biochemical factor was found. On univariate analysis, male gender and serum calcium levels were significantly associated with ocular complications. However, on multivariable analysis, after adjusting for covariates, we observed that the prevalence of ocular complications was 88% higher in males as compared with females. Moreover, with every 1 unit increase in serum calcium levels, the prevalence of ocular complications were decreased by 24%. These are the international literature search and studies. Jaffrey et al. Reported it to be 68.5% from Iran. Abdul Malik found it out 85% from Turkey, and Gartagenes from Greece reported 41.3%. Taneja et al. From India put it 58%. A lower frequency of ocular problems in our subjects might indicate successful transfusion and chelation therapy in our study population. However, this protective effect was not statistically significant in our study. This can be explained by relatively lower number of transfusion independent patients in our study, which is in line with the study findings of Hakpana et al. Reported in 2020. 31% of our patients had retinal pigment epithelial abnormalities. The frequency of retinal abnormalities in our patients was lower than what was reported in previous studies. One important finding of them was of foveal thinning identified on spectral domain OCT, which was found in 5 of our patients. Similar findings of foveal thinning were also reported by El Shazli et al. In 2016 in patients treated with subcutaneous deferoxamine. No significant association between the type of iron chelation used and the detection of foveal thinning was seen in our study. So in conclusion, regular eye examination are essential in managing ocular complications in children with thalassemia major. They aid in early detection of conditions, monitoring retinal health, assessing visual acuity, detecting cataracts and managing eye infections. These examinations would enable healthcare professionals to provide appropriate interventions and improve the overall ocular health and well-being of the thalassemia major children. Moreover, in future, follow-up studies can be conducted to establish temporality of beta thalassemia major and ocular complications. So this is our study which was published in British Medical Journal Open Ophthalmology last year. And I acknowledge Fatmid Foundation. Thank you.
Thank you very much, Dr. Rashid Beg, on your talk on ocular abnormalities on thalassemia patients. Now I request Dr. Sumaya Anjum to present her talk on the truth behind the scene. We are having a very short time. May I request Dr. Sumaya to be in hurry.
Bismillahirrahmanirrahim. Good afternoon, good evening, everyone. I'm Dr. Sumaya Anjum, and I'm working as assistant professor in pediatric ophthalmology department at Al Shafaa Trust Hospital. Welcome to my presentation, that is the truth behind the scene. No, it's not a movie title from Hollywood. Rather, we will discuss some interesting cases in which we will see that seemingly similar clinical pictures we get in clinical practice. They have a different diagnosis and different management. So pleasant surprises do occur in the world of ophthalmology. We will just jump onto the next slide. So let's guess. If we see this picture on the slit lamp, we will think about two diagnoses that comes to our mind. One is the pupillary membrane, because there is posterior synecdoche and there is leukocoria. And the second thing that comes to our mind is probably the cataract. So these two more pictures, you can have a look at them. So it's very difficult to see on the slit lamp, and especially in pediatric cases, whether it is a cataract or it's the pupillary membrane. So this is a video of one of the interesting cases. Surgeon is Dr. Hanif. He's making ports at 3 and 9 o'clock, and you can see here he begins the syneculisis with the help of the dialer. So as the surgery progresses, you will see that once the vitreous cutter is used and he starts to do the membranectomy in the next step, here you can appreciate, once the membranectomy is started, we can appreciate a very clear lens underneath. As Dr. Surat Nurani also, she discussed in her interesting cases in pediatric cataract, sometimes the lens is very clear once you remove the membrane. So we have to be very careful in devising our plan for the surgery, that we don't make extra wound or scleral wound or the corneal wound before deciding whether this patient really needs lensectomy or IOL implantation or not. So here you can appreciate from the retinal glow that the lens is totally clear. Moving on to the next video. This is also a small short video. Here you can see a very small pupil which is just, we can say that this is occlusal pupillae or a small festoon pupil. We cannot see anything behind it. But once the surgery is started, you will see that after membranectomy, we will find a very clear pupil. clear lens. So here, gentle syneculisis with the help of Sinsky. And once the vitreous cutter is used for doing the pupilloplasty and membranectomy, we can appreciate that there is crystal clear lens underneath. So, yeah, here you see the lens is very clear, and actually this patient was referred to us as a cataract, but the lens doesn't need to be removed at all. So pediatric uveitis is inflammation of the uveal tract, and it is a potentially sight-threatening condition. It poses very diagnostic and therapeutic challenges because of the unique characteristic of pediatric immune system and the subtle or non-specific nature of the symptoms in children. So it's 2 to 14% of all patients with uveitis account for the pediatric population. Although incidence of pediatric uveitis is known to be lower in children than in adults, but the children, they experience more severe ocular comorbidities and they affect the quality of life. So childhood onset of uveitis is uncommon and typically chronic, relapsing or recurrent in nature, with prolonged disease activity resulting in irreversible ocular structure damage. So these are the some of the etiologies which can cause pediatric uveitis: infectious, non-infectious, and vascular. So the basic definition which I am concerned with today is pediatric uveitic cataract, which is the lens opacity occurring due to the chronic inflammation of the uveal tract. And the second one is a pediatric uveitic pupillary membrane. So it's a fibrovascular tissue forming over the pupillary axis, which is different from the cataract, obviously, and it results from the prolonged inflammation or trauma. So we see the patient on the straight lamp, and for cataract, we can see, if for the straightforward cases, we can see the cataract is, the lens is hazy or white lens, and membrane, it appears as a dense tissue or fine tissue in the pupillary plane with the posterior synegy. There are a few other tests which can help us in differentiating these two conditions. One is anterior segment optical coherence tomography, and the other one is the UBM. It is useful when the cataract obscures the view. In these cases, intraocular pressure must be monitored to assess the glaucoma risk because it is very common with both of these conditions. So these are some differentiating factors in uveitic cataract. The location, it is in the lens opacity. In uveitic pupillary membrane, it is the pupillary plane. In uveitic cataract, there is no effect on the pupil initially, but in uveitic pupillary membrane, the pupil may be irregular or it can be occluded pupil, as we saw in the second video. Cataract extraction is needed in the uveitic cataract and uveitic pupillary membrane. It just needs membrane removal or pupilloplasty based on the severity. So as we all know, for uveitic cataract, we first have to control the inflammation, and then we go for the surgery and we implant a hydrophobic lens. And in uveitic pupillary membrane, medical management with corticosteroid and immunosuppressant to control the inflammation, and then we move on to membranectomy and pupilloplasty vision is threatened. So to conclude my presentation, early and accurate differentiation between uveitic cataract and pupillary membrane is critical, and we plan accordingly. And most of the time it is on the table, because sometimes people, they have already called for the IOL from the patient, or the additional cost is on the patient. So we have to be vigilant and avoid constructing unnecessary wound, and IOL implantation, if membranectomy or pupilloplasty can serve the purpose. And careful post-op management and care is very critical for the best visual outcome in all these patients. Thank you. So moving on to my next chart, it's hidden glaucoma in pediatric ectopia lentis patients. So ectopia lentis is a displacement of the lens from its normal position. It's a precursor to glaucoma especially in children as well, and it is very difficult to diagnose in children because children are very difficult to manage without anesthesia, and it's a silent yet potentially sight-threatening if it is left undetected and untreated. So I'm going to present a number of cases. First case is about a 4-year-old boy who presented with a vision of 8 CPCM in both eyes, and he was wearing aphakic glasses. And he was using these aphakic glasses for last 2 years. And eye examination, it revealed a megalocornea. And on slit lamp examination, it could be seen that he had bilateral clear lens subluxated into the vitreous. This is the B scan showing the lens, clear lens in the subluxated in the vitreous. He had iridodonosis, intraocular pressure was 30 and 28 millimeter of mercury, and CDR was 0.7 and 0.8 on fundoscopy. There were no systemic association and no family history. This patient was started on anti-glaucoma medication, triple therapy, and but the IOP was not controlled over the period of 2 weeks, so this patient was referred to the vitreoretina department, and the patient was booked for pars plana lensectomy. And patient was closely followed up for IOP monitoring. Case number 2 is about a syndromic child. He had sagittal craniosynostosis, high arched palate, hearing difficulties, and he had bilaterally superior-nasally subluxated lens. And his vision was 6/30 in the right eye and 6/60 in the left. He had shallow AC in superior quadrant and lens was tilted forwards. There was arterolenticular touch in the left eye. Intraocular pressure was 24 millimeter of mercury in both eyes. Retina was flat and CDR was 0.3. So this patient was actually having intermittent pupillary block glaucoma. So when we found this patient, his IP was just 24. Lens shift was causing myopia and lenticular astigmatism. Refractive error was -8 in the right and -15 in the left. And axial length was 20.87 in both eyes. So this is the picture. You can see that, especially in the picture on the left, you can appreciate that the lens is touching the iris. Patient was started on topical dorzolamide and timolol. He was urgently booked for left lensectomy, followed by the date for the right. Case number 3 is about 2 siblings. One was 6-year-old girl and the other one 12-year-old boy. Both had Marfanite habitus. The family history was positive with similar disease in paternal uncles. So visual acuity was in 1/60. In sibling number 1, it was 1/60 in the right eye and counting finger in the left. And the eye was in XT. And cyclorefraction, it revealed +10 and +8. Intraocular pressure was 18/4 in both eyes. His pachymetry was done and his corneas were a little bit thin. So 479 and 494. Axial length was 24 and 27 respectively in right and left eye. On fundoscopy, we found that he had 360-degree retinopathy and he had a myopic fundus. In the first picture, you can appreciate a small hole in the iris. That is, someone did peripheral iridectomy in this patient before this patient came to us. Sibling 2, she had visual acuity of 660 in both eyes, and the refractive error was +3 and with a CIL of +2 in both eyes. Intraocular pressure was 30 with Perkins in both eyes. This patient, she had a microspherophakia with nasal displacement in both eyes, and there was lenticular touch, and there was no zonular support temporally. So fundoscopy, she had a CDR of 0.6 both eyes, and axial length was also on the longer side, that is 26 millimeter. So these are the few tests we performed for this patient. You can appreciate some disc damage on OCT. Her both of these siblings, they had their homocysteine levels done. They were within normal limit. And on echo, the heart was structurally and functionally normal heart. So both these patients were booked for lensectomy. So we can see that incidence of glaucoma is almost 10% in the patient of ectopia lentis. Inheritance is both autosomal dominant and autosomal recessive. Age of onset can be congenital, it can be present at the birth, or it can appear in early childhood, or it can be of late onset as well. So there are different etiologies. According to that, there is different age of onset as well. It can be a primary manifestation of a systemic disorder. So past and family history and of cardiovascular and skeletal abnormalities is very important in these cases. So the most common ocular association of ectopia lentis are congenital glaucoma, chronic cyclitis, aniridia, high myopia, retinitis pigmentosa, megalocornea, buophthalmos, and persistent pupillary membrane. So I just included this picture just to appreciate that these, the most common refractive error which is associated with ectopia lentis is high myopia. So these two patients were wearing thick minus glasses. Marfan syndrome is the most common systemic association, and in these patients, 80% they present, 80% of patients they account for ectopia lentis, and 10% of these patients they have glaucoma. And then there is Weil-Marchesani syndrome, homocystinuria, hyperlasinemia, and sulfite oxidase deficiency. So what are the diagnostic challenges that we have in these patients? First is the silent nature of glaucoma. They don't have any symptoms. They are non-verbal usually, and they cannot tell you anything about any visual problems. Secondly, there is difficulty in detecting elevated intraocular pressure in these patients. Not all facilities, they have tonopen or Perkin, and then there is variable presentation in pediatric patients. So glaucoma, the mechanism of glaucoma, it can be congenital, it can be secondary to the pupillary block, and it can be intermittent, and then there can be anterior segment dysgenesis present. So our comprehensive eye exam is mandatory, and the role of imaging technique cannot be denied in these patients. Wherever it is possible, we should do OCT and axial length measurement. Gonoscopy is not easy in these patients, but should be done when possible in assessing angle structures. Optic nerve evaluation for disc damage assessment should be done with OCT, and visual field testing for detecting functional visual field loss. So management options include the correction of refractive error, amblyopia therapy, anti-glaucoma medications, topical and oral acetazolamide, and laser peripheral iridotomy, therapeutic and prophylactic in cases of microspherophakia. So it's a multidisciplinary approach. It's a collaboration between ophthalmologist, pediatrician, rheumatologist, and cardiologist. So dietary restriction is helpful in patient with homocystinuria, and cardiac evaluation must be done in all cases in which we suspect Marfan syndrome. Genetic screening and counseling is another important part, but not widely available. And there is a lot of focus should be on the patient education and patient's family education, because these are very long, these diseases have a very long course, and long-term follow-up and monitoring is important. So we do surgery in cases in which we have lens-induced glaucoma, or dislocated lens in AC with corneal endothelial touch, and lens-induced uveitis, lenticular astigmatism leading to amblyopia, retinal detachment, or if we find a subluxated lens or dislocated lens in vitreous cavity. So these are some surgical techniques. First is the lensectomy, in which there are two widely accepted approaches. One is the limbal approach, closed chamber lensectomy with interior vitrectomy. The other one is sparse planar vitrectomy with lensectomy. And for visual rehabilitation, aphakic glasses and scleral fixated IOLs and iris sutured IOL are the options. Shunt procedures are reserved for the patient in which the intraocular pressure is not controlled with lensectomy alone. And then cycloablation is used as the last restore. So to conclude, a detailed anterior segment, posterior segment, and systemic evaluation is necessary in ectopia lentis in each case. Management is tailored according to visual acuity, presence and absence of complications, and multidisciplinary management is the mainstay of these patients for the management, and we hope for improved detection and treatment in these cases whenever possible. Thank you so much.
Thank you very much, Dr. Sumaya. Thank you very much, Professor Zia and Professor Zabul, for chairing the session. We conclude this session with the take-home message from Dr. Levin that abusive trauma must be examined and reported for bring a change. And from Professor Seema Qayyum, eye is a window. Definitely, eye is a organ that gives us clues from many systemic diseases to make diagnosis. And excellent pearls of surgery from Professor Surat Noorani. इनकी शागिर्दी इख्तियार करनी चाहिए. And from Sara Farooq on Shabil syndrome. And then atypical presentation of retinoblastoma from Dr. Andalip Zahra. We should take pulse from her talk about the atypical presentation. And then Dr. Rashid Beg on ocular abnormalities of thalassemia. Routinely, the pediatrics physicians, they do deal with the thalassemia, but we come across very shortly, and very few cases are seen by us. However, with eye complications, as he has given us a vast variety of changes in ophthalmology, so we should take care of these patients as well. And lastly, Dr. Sumaya Anjum, he gave us an insight on the cataract and the papillary membrane misleading to the cataracts being the cause behind uveitis. And the pediatric uveitis she narrated very well, and also give insight on the different cases of ectopia lentis leading to glaucoma. So thank you very much for your patience and having on board for this session. Lastly, I request to all have a photo session.